Ladies and gentlemen, my name is Nattapol Thammachote from Thammasat University. Today I'm gonna share with you about how to achieve painless knee replacement. The outline of my talk will be about most of the patients suffer from pain after knee replacement, and it is one of the most concerned issue of the patient. About the contemporary concepts in pain control after knee replacement. And then the last thing is about my practice and the result I have achieved. As we all know that total knee arthroplasty has produced moderate to severe post-operative pain. It has been known that it is the most painful procedure in orthopedics. Why? Because the knee have a rich sensory innervation and also have a very wide range of motion. The pain after knee replacement may result in prolonged hospital stay, will diminish patient satisfaction after surgery, may prolong functional immobility of the patient, and may increase opioid consumption, and may result in patient addiction and increase the rate of adverse event. The satisfaction after surgery. In hip replacement, we have more than 90% satisfaction, but in knee replacement, the rate of satisfaction is still at the 80%. It means that 20% of the patients still feel unhappy after surgery. There was a study from Korea asking the patient what their concern from the surgery after knee replacement. The most concerned issues is the pain, whether the pain immediately after surgery, the pain after discharge, the pain not alleviated from surgery, or the pain during surgery. The level of concern of pain before having surgery. If the surgery is a life-threatening procedure, such as the cardiac surgery, the patient will have less concern compared with the study that just improve their quality of life, like a knee replacement or corneal replacement. The pain have been assigned as the fifth vital signs. So if you can provide a good pain control, it will increase the patient satisfaction and it will enhance the recovery to get it faster. As I have already mentioned, knee replacement have been the most painful procedure in orthopedics. So is it possible to make it pain-free? I will let you see the video from the patients. This patient said that there's no pain at all after surgery or during surgery. So how can we deal with the pain? The key message is we have to use multiphasic, multimodal analgesia. We have to attack the pain from preoperatively, intraoperatively, and post-operatively. In the preoperative period, we have to provide the patient the most insightful education and a realistic expectation to decrease the patient anxiety. If the patient understands what he gonna see or what's gonna happen, they will feel much less anxiety and they feel more confident with the procedures. We provide the patient with the preemptive analgesia. The preemptive analgesia means we have to treat the pain before the painful stimulus happened. There's many drugs for the preemptive analgesia, such as acetaminophen, non-steroidal anti-inflammatory agent, steroid, gabapentin, and pregabalin. Acetaminophen, whether oral or IV form, have been shown to reduce the COX-2 level in brain and reduce the pain stimulus. The gabapentinoids, even it didn't have a clear mechanism, it showed that it will reduce the central sensitization of nociceptive and inflammatory after surgery. It will help relieve. The pain relief effect of pregabalin is more than gabapentin. Steroid is a very wonderful drug to control pain. Most of us know that steroids have a very strong effect to reduce inflammation. That's RCT showing that methylprednisolone or dexamethasone reduce pain after surgery. But we need to have a proper dose of steroid for preemptive analgesia, which was suggested to be more than 0.1 milligrams per kilogram. We published a study comparing the intravenous dexamethasone injection with the placebo in controlling pain after knee replacement. We used 1.15 milligram per kilogram of dexamethasone and found that it can reduce pain at rest and on motion up to 21 hours after surgery, and also decrease the nausea vomiting. So when we have drugs for preemptive intraoperative period, we also have to have a good anesthetic technique, and we found that the regional anesthesia is more efficient than the general anesthesia in controlling pain after knee replacement. We use a spinal block, epidural block, and peripheral nerve block become more and more popular. At Thammasat University, I think it is the first place in Thailand that use local infiltration using the anesthetic cocktail to inject in the knee after knee replacement. It helps improve the pain and reduce morphine consumption, and it can be easily done by surgeon, and there's a very minimal complication. The ingredient of the anesthetic cocktail include the anesthetic drugs, the NSAID, the opioid, and epinephrine. Some surgeons may also use the steroid. This video shows where to inject the anesthetic drug. We have to inject at the posterior capsule and systematically inject around the knee where there's soft tissue injury, where we cut the soft tissue and bone. We inject around the quadriceps muscle. Normally, we prepare the anesthetic cocktail approximately 100 cc and inject around the whole knee, from quadriceps down to pes and serinus. Also at the fat pad below the patella, at the synovial tissue also. We did a study and published in Clinical Orthopedic and Related Research, found that compare the anesthetic cocktail injection with the spinal morphine using a double-blind randomized control trial. The anesthetic cocktail injection have a comparable pain control capacity with the spinal morphine 0.2 milligrams, but it reduced the rate of nausea, vomiting, and pruritus for 2 and 4 times. We also did another study comparing using a multimodal drug to inject like the anesthetic cocktail, or we should use a single anesthetic drugs. And we found that if you use multimodal drugs, it have longer pain control and longer time for the patient to request the first dose of analgesia. It extend the first dose request approximately 2 hours. And there was a meta-analysis about the local infiltration of the analgesia and found that we have to inject periarticular. We should not leave the anesthetic cocktail intra-articular. It provides a lower pain and provide less opioid consumption and have a lower length of stay and higher knee motion. But the patient journey for post-operative pain is not only during surgery. The post-operative period is very important. I provide the talk divided into 2 parts: the immediate after surgery and also the subacute pain in the first 1 or 2 months after surgery. For the immediate pain after surgery, I think the multiphasic, multimodal pain control regimen have been taken care of. We use NSAID, opioid, We use many kind of oral medication because knee replacement become ambulatory procedures. We prescribe NSAID, Tramadol, Tylenol, Pregabalin.
หายแล้วกลับมาที่ห้องพักไม่รู้สึกว่าป้าจะผ่าหัวเข่าเลยไม่รู้สึกอะไรเลยเมื่อคืนก็นอนหลับดี
She feel that
ตัวนี้ปวดไหมครับ
she didn't have pain at all and
เจ็บไหมครับผ
she
ม
don't feel she have
เจ็บ
surgery.
ไม่เจ็บเลยเนาะ
ไม่เจ็บเลย
งออีกทีได้ไหมครับ
ต้องใช้มือจับเนาะ
เจ็บไหมไม่เจ็บเลยเนาะ
ไม่เจ็บ
Control her knee. She
ครับ
can bend her knee as much as she would like. This is another patient. At first, he thought that he's gonna feel very painful after surgery, but on the second day after surgery, he didn't feel pain at all. He can bend his knee. He can do anything he would like to do. At the discharge time from the hospital, the patient can bend their knee quite well. But the most important part is the pain after discharge. I think nowadays most of the surgeons in many hospitals in Thailand, we can control the pain immediate after surgery at the hospital stay very, very well. But the pain after discharge is another thing. Most of the patients tell me that when I'm staying with you in the hospital, I feel very, very good. But when I got back home, it's opposite sides feel very painful. And there was a study showing that more than 50% of the patients suffer from the subacute pain. So we think hard about how to deal with the subacute pain after knee replacement. And we published another important study in JBJS, American Volume, in 2018. We found that the lumbar epidural steroid injection can reduce subacute pain and improve knee function in the first 6 weeks after knee replacement. We compare the analgesic efficacy of the epidural steroid in controlling pain in the first 3 months after knee replacement. One group, the patient received the triamcinolone acetonide with 1% lidocaine, and another group, they received only 1% lidocaine. We found that the pain on motion is about 30% better in the patient who received steroid in the first 6 weeks, but the pain at rest is pretty similar. The patient also have better knee function in the first 6 weeks after surgery. So the conclusion is epidural steroid can reduce pain in the first 7 weeks and provide better knee function in the first 6 weeks after knee replacement. It may improve the patient satisfaction after knee replacement. This paper was interested by many society. I was invited to talk about the study in the European knee in London and in the EFORT meeting in Vienna. So now I'm gonna share with you about the practical point what I have done to control the pain after knee replacement at Thammasat University. We gave the preemptive analgesia with pregabalin 75 mg oral and lorazepam 0.5 mg oral the night before and in the morning of surgery. We also have a preemptive dexamethasone 8 to 12 milligrams before surgery. If the patient can sleep well the night before surgery, they will feel better. And most of the patients have a lot of concern due to the surgery. It's quite a big procedure. They have a lot of worry, so they can't sleep well. Intraoperatively, we provide a spinal block with anesthetic cocktail, or we use combined spinal epidural block also plus anesthetic cocktail. We use a meticulous surgical technique. We use no MIS because I believe that the sharp incision of the soft tissue will provide less pain. We use low pressure tourniquet, just systolic blood pressure plus 100 and 120. We use periarticular injection with the combination of drug I have already mentioned, the anesthetic, the analgesia with the morphine, ketorolac, epinephrine, and mix it to 100 ml. The post-operative drug is the intravenous NSAID around the clock intravenous morphine, PRN. We prescribe the Tylenol, Tramadol. We use the oral medication as soon as possible to encourage the patient to recover as soon as possible. We have no NPO after surgery. And we have provide cold compression and also foot pump exercise. This is the flow chart of the patient 4 or 5 years ago. Nowadays we have a shorter length of stay. The length of stay at Thammasat University is about 2 to 3 days now. Let's see what's the patient talk about. This is the 2 weeks after surgery. The patient can bend the knee quite well. This patient have 2 knee surgery done at the same time, the bilateral knee replacement. She can bend both of her knee quite well if she feel pain-free. This is another.
หลังผ่านี่ต้องดูตามแบบสี่ขาก่อนครับก็ดีครับไม่เจ็บไม่ปวดไม่รู้สึกอะไรไม่เจ็บไม่ปวดไม่รู้สึกอะไรก็ทำตามที่คุณหมอสั่งทุกอย่างตอนแรกผมขาโป่งนะฮะแล้วพอผ่าแล้วก็ขาก็ตรงใกล้เคียงกับปกติมากเลยครับก็ถือว่าดีครับพอผ่าเสร็จเนี่ยไอ้ความรู้สึกเดิมๆผมว่าผมน่าจะมาผ่าตั้งนานแล้วผมไม่รู้สึกเจ็บปวดเลยหลังจากผมไม่รู้สึกเจ็บปวดเลยหลังจากผ่าตัดมาเที่ยงครับ
long time ago before he have surgery. Let's see how's the move.
หมอก็ให้หัดเดินก็เดินได้มันไม่ปวดปวดบ้างนิดหน่อยกินยาเรื่องปวดนี่มันน้อยที่สุดเลยเรื่องปวดนี่มันน้อยที่สุด
So if we provide a good pain
ที่เดียว
control.
นั่นเลยทุกกิริยาปวดทำก็เปลี่ยนลงตะแคงได้หมด
If we provide a pain control, the patient will have a good rehabilitation and have a good knee function. But behind the scene is not the only surgeon work. We have to have a teamwork with the anesthesiologist and also the internal medicine doctor to provide the condition of the patient to be able to prescribe the proper pain medication. So my conclusion is the pain is the most concern issue of the patient. I think not only knee replacement but also in many surgical procedures. If you provide a better pain control, you will get a better cooperative and happier patient. The technique is the multiphasic, multimodal approach to effectively control the pain, and one of the new knowledge is the epidural steroid can reduce subacute pain after knee replacement. Like Nelson Mandela quote, it always seems impossible until it is done. I thank you very much for your attention.
Thank you, Dr. Nattapol, for your presentation. Any question, you can send it by chat box. Okay, so there is no question. So thank you again, Dr. Nattapol, for your presentation.
Thank you very much.